My task today is to present the metallic biliary stenting in non-hilar malignant strictures. Regarding the metallic stents, we have three different types of stents. The first is the uncovered metallic stents, or fully covered metallic stents, at which they are covered with silicone layer. There is a third type, which is partially covered, which means that the proximal and the distal half to 1 centimeter of the stent is uncovered, while the rest and the middle part of the stent is covered with a silicone layer. Each of them has special indication and advantage and disadvantages. The advantage of the uncovered stent that they are stable, they are not migrating, but the disadvantage, after long duration of stenting, tumor ingrowth could happen in these cases. The uncovered stent has advantage to avoid the tumor ingrowth inside the fenesters of the metallic stent, but they have a high rate of migration. Regarding these stents, the covered stents has another option or advantage because they are removable, and there is a lasso at its distal end facilitates retraction of the stent in case of removing indications of the stent, while the uncovered stent, there is no lasso because they are unremovable. Each stent retracted in its cheese, they have radio-opaque marker at its distal and proximal end. Of course, these stents are inserted over a guide wire after stabilization of the guide wire inside the biliary system. And there is a different available length for each stent, whether it's 6, 8, or 10 centimeter in length, according to the length of the stricture inside the biliary system. Of course, these metallic stents, there is no contraindication to perform MRI because they are conditional for magnetic resonance imaging. So there is no contraindication for MRI later on after stent insertion. The fluoroscopic imaging and SEMS insertion is very important to put 4 landmarks before stent deployment. If this is the endoscope, and this is the duodenal wall and the papilla, here is the pancreatic duct under the fluoroscopic image, and this is the common bile duct. The first point is the level of the stricture. We should know after injection of contrast media where is the proximal end of the stricture. And also we need to know where is the level of the papilla. We should insert the metallic stent at least 1 centimeter above the proximal end of the stricture, and we have to know the relation of these point to the cystic duct or the liver hilum. The fourth thing, at least 1 centimeter of this stent should protrude from the papilla, and we have to avoid elongation of this part in order to protect the opposing wall of the duodenum from any trauma or injury. We have today a case of male patient, 80 years old, presented with jaundice of 2 months duration. His CT is showing single hepatic focal lesion in the left level loop, and there is mass in the pancreatic head measuring 5 centimeters in length. This patient has a bilirubin of 8 milligram per deciliter. Now we will start an ERCP with selective cannulation with a sphincterotome in the direction of the common bile duct from below to up, opposing the 11 o'clock position. And then we will try to insert the guide wire inside the sphincterotome into the CBD very gently before injection of any contrast. When the guide wire is inside the biliary system, we start to inject contrast media. As we see here, there is dilatation, and this is the level of the stricture below the shaft of the endoscope. and this is the distal end of the CBD. We will keep the guide wire inside the bile duct after measuring the length of the stricture, and then we choose or select the proper length of the metallic stent according the evaluation and measurement. This is the cheese of the retracted metallic stent. As we see, it's totally retracted inside the cheese, and this yellow end means yellow color shows the end of the distal end of the cheese. This is the distal end. We have to keep this distance at least 1 centimeter outside the papilla. Under the fluoroscopic picture, we see the radio-opaque markers is above the level of the biliary stricture or the biliary lesion, and then we keep this fluoroscopic image together with the distal end during deployment of the metallic stent. Now the stent is fully deployed with good bile flowing out, with the radio-opaque, and the upper part of the stent is proximal to the stricture, and the distal end is not more than 1 centimeter outside the papilla. And now we are seeing the bile is flowing out smoothly from the biliary system after good drainage. Now we do fluoroscopic image. We see some contrast in the intrahepatic biliary system, especially in the left branches. We will try to wait a little bit to check the complete evacuation of the biliary system. As we see here, all contrast has been drained with successful drainage of the biliary system. Which metallic stent we should choose in case of malignant non-hilar biliary obstruction? At the first, sphincterotomy is not necessary for inserting single plastic or metallic stent, but they might facilitate more complex procedures, so it's not important to do sphincterotomy before stenting. If the life expectancy of the patient is less than 4 months, then plastic stent 10 French is satisfactory, while if it is longer than 4 months, then metallic stent will be warranted. Covered or uncovered, still unproven, which is one is superior to the other. If there is no definitive management decision taken before ERCP, then plastic stent would be indicated. Metallic stent should be considered in patients undergoing other therapies. Theoretical benefit of prolonged patency with fully covered stent versus uncovered stents are still unproven. Fully covered stents is potentially removable if the presumed malignancy diagnosis was incorrect. 6 centimeter in length stent uncovered are warranted if malignant stricture, and fully covered are indicated in benign stricture because they are retrievable.